Good afternoon, everyone. Today we're going to discuss the physiologic and behavioral adaptations of the newborn. And we'll start off by looking at breathing, the initiation of breathing in the newborn. How does the newborn, how do they do that? What stimulates them to take the first breath? Well, we know that in utero, they've been relying on maternal circulation for its primary oxygenation, but now the baby has the huge task of figuring out how to breathe on its own. And of course, there are various stimuli, as you can see across the top of the slide, that causes the initiation of the first breath. Let's look at the chemical stimuli, which is basically changes in the O2 and the CO2 and the pH level, which drops, and that causes the respiratory center in the brain to realize it needs to breathe. As you know, increased CO2 causes stimulation of the brain. The baby's diaphragm will contract, and that will stimulate them to take the first breath. There's also sensory stimuli, such as sounds in the operating room, the surgical area, or in the room where mom is giving birth. There are lights, there are smells, the baby is being touched, and unfortunately, there's some pain involved. We're rubbing the baby's heels and we're doing everything we can to get those babies to cry vigorously because that opens up their alveoli and gives them a better chance in having a healthy first few hours of breath. And more specifically, when they vigorously cry, it pushes out any residual amniotic fluid in the lungs and replaces it with air. Of course, there is thermal stimuli. They go from that nice, warm, watery environment to a cold environment. Even though we try very hard to keep the baby warm, that's the goal. The number one goal is to keep the baby warm and dry. But there is a change in temperature. So that's going to contribute to the respiratory effort. And finally, there are mechanical stimuli. That is the chest compression that occurs as the baby moves down the birth canal through the vaginal opening, and to a lesser extent with cesarean births. So there is a positive effect of the baby going down the birth canal, because as the baby's chest is squeezed, it causes fluid to be forced out of the lungs. And when the baby takes the first breath, then the residual fluid is pushed out and exchanged with air inflating the lungs. Okay, so let's look at the neonatal period, from the birth through the first 28 days of life. This is when the newborn is experiencing both physiologic as well as behavioral adjustments to life. We know that in utero, mom was responsible for maintaining oxygenation of the newborn, the circulation, the body temperature, feeding the baby. There was an elimination of waste in utero, and the baby either grew and gained weight or did not. This was all based on what was going on with mom. But now, as a newborn, all of those physiologic change adjustments must take place. So if we start with establishing and maintaining respirations, now they have to do that. Now the newborn is responsible for doing that. Adjusting to their circulatory changes, regulating their body temperature. They have to feed and retain nutrients and digest those nutrients. They have to eliminate on their own and regulate their weight. These are all functions now that the newborn is responsible for doing. And as the nurse, we are responsible for monitoring and ensuring that those changes, those physiologic changes, are taking place and they are within normal limits of expectations. The newborn behavioral adjustments. In the past, baby slept in utero, was exposed to stimuli through mom's uterus, and there was no other relationship besides those that mom came in contact with. But now, as a newborn, this baby is regulating its own sleep and wake cycles. It's processing all of these various stimuli. If you think about it, from the very time of birth, there are all kinds of sounds and noises and smells and people talking and laughing and the equipment being used and maybe a suction machine going, all of these things that baby has not been exposed to before, as well as coming in contact with people. They're used to hearing their mother's voice and the voices of those around the mother. But now there are other people that this baby is coming in contact with. So these are all adjustments that the baby will have to go through. So let's look at the psychosocial adaptation that occurs in the newborn. This period consists of 3 periods of reactivity and 6 levels of consciousness in the newborn. The first period of reactivity occurs in the first 30 to 60 minutes after birth and is described by an alert, exploratory, and active newborn. This is when the suck reflex is the strongest. So optimal time to place the baby on the breast. Assist the mother with positioning, pillows under her arm if necessary. Help her with the latch on so that baby will suckle on the areola and not just the nipple. That would lead to possibility of cracked or sore nipples. But this is the ideal time to place the baby on the breast. If you can do it with skin to skin contact, that's ideal. Place a warm blanket over the baby and make sure baby stays warm. And then if mom is cold, you can put blanket on mom as well. But that first period of reactivity, you want to maximize that by placing the baby on the breast. During this initial period, the newborn may be a little bit tachypnic or tachycardic, but that is normal during this transitional period. Then there's a period of relative inactivity. This takes place about 2 to 4 hours after birth. And this time, the newborn becomes less interested in external stimuli and falls asleep for a few minutes to several hours. During deep sleeps, the baby is difficult to arouse. Feeding may be difficult. The heart rate should stabilize at about 100 to 140 beats per minute, and the respiratory rate decreases to 40 to 60 breaths per minute. So the newborn at this point should be pink, have fairly clear breath sounds, and show no signs of respiratory distress. And then the second period of reactivity, this occurs between 4 and 6 hours after birth. This period will last from 10 minutes to several hours. And the heart and respiratory rates during this period may increase, but still should remain within normal limits. So now let's look at the physiologic adaptations. Okay, so let's look at respiratory adaptation. We spoke earlier about the establishment of respirations, but there are times when there are indicators of respiratory distress. And as the nurse in the room with the newborn, you need to be aware. Let's just start with the first one, grunting. Mm, 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 is the sound of grunting. This is the sound the baby makes when they're experiencing respiratory distress. And sometimes mistakenly, the parents think this sound is cute. The baby's making a cute little noise, but it's not cute. Grunting is the sound of a baby who is struggling to breathe, and it needs to be addressed immediately. Flaring is when the baby's nostrils get larger as they struggle to breathe. Now, babies are nose breathers, but if they're having trouble breathing through their nose, you will see flaring of the nostrils. Next are retractions. And retractions, if you look at the newborn without a shirt on, you'll see the rib cage and skin covering the rib cage. A baby experiencing respiratory distress, you will see the skin start to indent when the baby breathes. So the ribs become more prominent. This is an irregularity. This is signs of distress. These are changes that you need to be aware of, alert for, and be ready to address immediately. Babies do normally have an irregular breathing pattern with periods of apnea. So the baby's breathing may be breath, breath, pause, breath, 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 pause. And during those periods of pause, those periods of apnea, that is normal as long as the periods of apnea do not last longer than 20 seconds. If they last longer than 20 seconds, that is a problem. Before I move on, you need to educate the family about this normal, irregular breathing pattern because parents, family, they watch the baby sleep. And if they see this irregular breathing, especially the periods of apnea when the baby stops breathing, they become alarmed. But do reinforce the fact that the periods of apnea are normal as long as they last less than 20 seconds. Sorry. Bradycardia and tachycardia can also be signs of distress. So make sure you check the fetal heart rate, the newborn's heart rate. Cyanosis, or the bluing of the skin, can be a sign of distress, especially when it's noted around the baby's lips. Cyanosis is different from acrocyanosis. Acrocyanosis is a bluish color of the extremities, the hands and the feet. And this is okay, but the core of the body should be pink. And the reason this is okay is because remember, circulation, adaptation, this is just getting started. The circulatory system is immature. These extremities are the furthest away from the heart. So it takes a little while for that circulation to really become mature. But acrocyanosis, acceptable. Cyanosis around the lips, not. Cardiovascular adaptation. Um, and this is transition we talked about earlier from fetal to newborn circulation. So when the lung inflates, there is a decrease in pulmonary resistance, an increase in pulmonary blood flow, a decrease in pulmonary arterial pressure, and decrease in the right atrium pressure. So all of those changes together, they trigger the anatomical closures that are necessary. The first one being the ductus venosus. When the umbilical cord is clamped and cut, it stimulates closure of the ductus venosus. Then there is the foramen ovale, which begins to close when increased pulmonary blood returns to the right atrium, when the pressure increases in the right atrium. Those two changes stimulate the closure, the initiation of closure of the foramen ovale. However, permanent closure takes several months. And then the ductus arteriosus, it also begins to close or constrict as oxygen levels increase in atrial blood. And this is a beginning of the closure or constriction. However, permanent closure begins around 3 to 4 weeks of age. And sometimes you'll hear people have heart murmurs, and heart murmurs are something that we check for in the babies as well. Heart murmurs can be transient because remember I said some of these closures takes several weeks to several months to be completely closed. So as they are closing, you should start to hear less and less of the murmur, but in some cases the murmur does not go away, and it either is symptomatic or asymptomatic. If it's symptomatic, there may need to be some intervention. One of the challenges of heart murmurs is that there is an exchange of oxygenated and deoxygenated blood. So again, if the infant is symptomatic, then there may be a need for an intervention, but that's not always the case. Okay, so hematological adaptation. Hematological adaptation. Red blood cells. In utero, fetal circulation is less efficient at oxygen exchange than the lungs. So remember, the lungs are being bypassed at this time. So the fetus needs additional red blood cells for the transport of oxygen. After birth, the red blood cells decrease until about 8 to 10 weeks of age. So you'll see elevation in the hemoglobin and hematocrit because of the increased red blood cells. However, the platelets and the white blood cell counts should be within normal limits. So the blood marrow is the largest organ, major organ in the hepatic system. In utero, red blood cells relate to low oxygen saturation. So because of low oxygen level in the blood, just remember, because of the low oxygen level in the blood, the baby will have more red blood cells. Thermogenic adaptation. So babies are not born with the ability to regulate their temperature. The goal in caring for the newborn of thermoregulation is very important. We want to maintain a thermal neutral environment. At the time of birth, babies are cold and wet. So our goal is to get them dried off, place them in a preheated infant warmer, or place them in skin-to-skin contact with the mother. If you think about yourself, I try to use this analogy. If you think about yourself, turn the air on in your house at 60 degrees. You go and take a shower or a bath, and then you stand out in that air without drying off and nothing on. That's what the baby feels like. Heat generation for newborns is through vasoconstriction, increased metabolic rate, increased muscular activity, and non-shivering thermogenesis. When we get cold, we shiver. Newborns are not born with the ability to shiver. If you see a baby that appears to be shivering, what you see may be tremors, and in most cases, the most common reason for that is low blood sugar. But heat in the newborn is produced through brown fat metabolism. So if the baby is cold, the brown fat that they have stored in around the shoulders, the axilla, the thorax, the lumbar area, the kidneys, that brown fat begins to be metabolized. That causes stress in the baby. And this brown fat is limited in storage. The amount there is limited, so it will be depleted when the baby is exposed to cold and they are burning calories and releasing heat, trying to warm themselves up. We need to do that for the baby. The consequences of the baby remaining cold is the development of cold stress. This is a situation in which the brown fat metabolism can result in increased respiratory rate and effort. It can result in hypoglycemia in the baby, hypoxia, metabolic acidosis, and even death. So warming and keeping that baby warm is very critical. Thermogenic adaptation, still, the effects of cold stress are those things that I just mentioned. But how does the baby lose heat? There are several different ways, or four specifically, that the baby loses heat. One is conduction. This is when direct heat loss is lost to solid surfaces with which they are in contact. That can be a warmer that has not been preheated. It can be placing the baby on a cold scale, getting their weight. It can be placing them on a cold blanket that has not been pre-warmed. Next is convection. And this is heat, when heat is lost based due to currents in the air. So you want to make sure that in the area where you are caring for the newborn, that there are no air vents blowing in that area. Heat can also be lost through evaporation, and evaporation heat loss occurs when water evaporates and from the skin of the baby, and it takes heat away with it. So the way to minimize heat loss through evaporation is to have several warm blankets. And each time you wipe the baby with a warm blanket, you get rid of it if it's wet and get another dry, warm blanket. And you do that until the baby is completely dry so that there are no wet areas on the baby as a source of evaporation heat loss. And finally, radiation. Radiation heat loss can occur through electromagnetic waves from the skin to surrounding surfaces. So you think about it, the equipment that you're using to check the baby's blood sugar. It's cold, it pulls heat away from the baby. The thermometer that you're using, if it's cold, it pulls heat away from the baby. So everything that comes in contact with the baby, you want to make sure it is pre-warmed, that you're dry, the baby is dry, that you're taking every step, every measure to do what? Maintain a thermal neutral environment. Okay, so let's look at the hepatic adaptation. So coagulation factors are produced through the liver. However, the baby's intestines are sterile at birth, and they don't have the intestinal bacteria that are needed to synthesize vitamin K, so babies receive an injection of vitamin K at birth. Later on, they will begin to synthesize their own vitamin K. Because the liver is immature, it's difficult to process bilirubin from the lysis or breakdown of red blood cells. So this increases the risk of jaundice in the newborn. There are two forms of jaundice that are related specifically to breastfeeding. One is breastfeeding associated jaundice, which is early in onset. This type of jaundice is usually related to problems breastfeeding, baby not latching on well. Mom may be experiencing a lot of pain with breastfeeding. Mom's nipples may be sore or cracked. So the baby is not getting enough breast milk to clear the bilirubin from the baby's system. Breastfeeding associated jaundice is usually early in onset. The other type is breast milk jaundice. And for some reason, there are some people in some situations where the breast milk itself causes jaundice or results in jaundice. And whatever the pathophysiology is around that, that is one source of jaundice, and it's usually late in onset. So when the milk really comes in, then the jaundice tends to get worse. Of course, bilirubin itself is the breakdown of red blood cells. It's a byproduct of the breakdown of the red blood cells. It results in hyperbilirubinemia, which leads to jaundice or the yellowing of the skin, and then kernicterus, which can result in, it's a toxicity of bilirubin. When the level becomes so high, it becomes toxic to the baby. Of course, there are several interventions as a nurse that you need to be familiar with as it relates to hyperbilirubinemia. One is the exposure to the sun or vitamin D helps with the breakdown of bilirubin. And as the bilirubin is broken down, it binds with the stool and is excreted from the body. The other is, of course, the ultraviolet treatment, where the baby's eyes and genitalia are covered and baby is placed under an ultraviolet light with a heat source to help break down the bilirubin. And I'm going a little bit more into detail about this than is necessary for this slide, but some of the issues with babies under the bilirubin light has to do with the bonding. Parents, although they understand it's in the baby's best interest, they don't like to see the baby under the bilirubin light. They want to bond with the baby. The babies sometimes are fussy and don't want to stay under the light. They want to be held. But it's always important to reinforce why you're doing what you're doing to the parents so they are informed. And then carbohydrate metabolism. So glycogen is stored in the liver and converts after birth before feeding start. The glucose level, normal glucose of a baby should be between 50 and 60 milligrams. But when the newborn is stressed, as is the case with cold stress, they use glucose and they then can't maintain their normal glucose levels, so they develop hypoglycemia. So what are the symptoms of hypoglycemia in a newborn? Well, we talked about tremors earlier, earlier, or shakiness. There can be a blue color to the skin and lips, or cyanosis, or paler. Babies can actually stop breathing. They can start breathing fast. Their temperature, they have a problem maintaining a normal body temperature. They can develop poor muscle tone, not interested in feeding, lack of movement and energy. They become very lethargic. They can have seizures. They can develop a very weak or high pitched cry. So the baby is just compromised when they are experiencing hypoglycemia. Let's look at gastrointestinal adaptation. Feeding behavior in the newborn can be impacted by their gestational age. So you're looking at a preterm infant will not have the same feeding ability as a term infant. Their neuromuscular maturity. We talked about the suck reflex that is prevalent during the first period of reactivity. The maternal medications that may have been taken during labor and birth may make baby very sleepy, so it's difficult to feed them if they're sleepy, as is the case during that second period of reactivity, of the period after the first, where the baby goes into a deep sleep, the deep sleep period. Very difficult to feed the baby. And then the type of initial feeding. Some babies do better on the breast, some do better with a bottle. It varies. Breastfeeding, babies suck very differently than they do with the breast. Than they do with the bottle. So you want to make sure that you're not confusing the baby with different types of feeding between the bottle and the nipple. If the baby is going to be breastfed, it's preferable that they receive all of their feedings, either through the breast or some other mechanism, but not necessarily expose them to the nipple if that can be avoided. Babies have bowel sounds at about 1 hour of age, starting at 1 hour of age. The stools, once they start feeding, they will have stools. The first stool is the dark, tarry, sticky meconium stool. They usually have that stool anywhere from the time of birth up to 48 hours after birth. Then they have a transitional stool, which is a little less meconium looking. And this occurs 2 to 4 days after birth. And then the stools change based on the type of feeding. Breast babies have a golden yellow cottage cheese looking seedy type of stool. And we're talking about 4 days of age and on. And then the bottle, that's wrong, it's the bottle fed babies have a a different type of stool. It's usually a brown stool, but it kind of depends on the type of formula that the baby is ingesting. And that stool will remain starting at 4 days of age and continue. And then the gastric capacity of the baby is anywhere from 30 to 60 milliliters. They may start off very small amounts, and within 3 days, they should increase the amount. So if they're at 30, eventually they should start taking more nutrition in, up to 90 milliliters in 3 days. And this can vary. Some babies take in less, some take in more. You want to make sure the baby is burped in between at intervals, different intervals during the feeding. The renal system, an infant who is not voided by 24 hours should be assessed for adequacy of fluid intake. And one of the ways you measure, if you're concerned about a baby's voiding, because sometimes it's just a very small amount and it's clear, and if you're looking at the diaper for signs that the baby has voided, you may actually have to tear the diaper, the plastic portion, to see if the stuff, the inside of the diaper shows evidence of moisture. Another way you can determine if the baby has wet the diaper, if it's not obvious, is to place a dry diaper on the scale and weigh it, and then weigh the diaper that you take off of the baby, and the difference between the two will be the amount of fluid that urine the baby has voided. Bladder distension, you need to assess for if the baby has not voided. Restlessness or signs of discomfort are also things that you need to assess for if the baby is not voided in 24 hours. In the renal system, we want to monitor fluid and electrolyte balance, as well as signs of renal system complications. The immune system response at birth is reduced because the baby, remember, the intestines are sterile when they're born. Breastfed babies begin to get immunity from the mom through the breast milk, as well as they develop immunity on their own in time. But at birth, they are more at risk for infection because of this decreased or reduced immune response. Neonatal levels of circulating immunoglobulins are low. Many components of the breast milk strengthen the neonate's immune system, and then the risk for infection, you want to monitor for early signs and symptoms of infection. And the greatest risk for neonatal infection is prematurity. They're already at risk because of low levels or reduced levels of immunoglobulin, but they're also at increased risk because on top of that, they are premature. So there are other complications that go with that, and all of that together increase the risk for neonatal infection. The skin, assessment of the newborn skin, vernix. And if you've been through labor and delivery, I'm sure if you've seen a delivery, you probably have seen vernix, which is the white cheesy covering on the baby. It protects the baby in utero, protects the skin. Lanugo is the fine downy hair. You'll see some babies have an abundant amount of lanugo, some very little, but it normally falls off. It can cover the arms, the legs, the stomach, the back. Some babies have it around their face, on the sides of the face. Again, it does usually, the babies lose that. The milia are just the little white bumps that occur on the skin. No need for alarm. You need to educate the parents and let them know that this is normal. The red blotchy skin, you see a picture of it on the slide. Birthmarks, there's a picture as well. Mongolian spots in the sacral area is the bluish, greenish discoloration of the skin, more prominent in darker skinned newborns. Port wine stain is another type of skin assessment, as well as strawberry hemangioma, usually on the head, and you can see that on the top picture. This does usually appear on the head, but it disappears by school age in most cases. Reproductive system, the male and the female, swelling of the breast tissue caused by the increased level of estrogen can be evident in both male and females. Um, as the level begins to subside, the breast swelling does go down, but this is a very common finding. Part of the assessment of the newborn is to measure the amount of breast tissue present at the time of birth. Signs of reproductive system problems. These are some of the things that you would see to note and to address immediately. Ambiguous genitalia, hypospadias, undescended testes, and inguinal hernias. And these are all picked up during assessment of the newborn. The skeletal system. So if the baby has been wedged in the birth canal for some time, and either is delivered by vaginal birth or cesarean birth, you may see some molding of the head. And that's caused by the bones overlapping to accommodate the pelvic area and the vaginal outlet for birth. That usually resolves itself within a couple of days. Within a couple of hours, in fact, you can start to see differences. And in some cultures, it's not uncommon for family members to quote unquote shape the baby's head. But please use that as a teaching opportunity to let them know that the bones of the head will go back into the shape that they should be in time, and there is no need to massage or shape the baby's head. There are two situations that you may see some swelling of the head that are not related to molding. One is caput, and caput is a collection of fluid or serum that occurs under the scalp. Caput crosses the suture line, so you'll see the swelling may be kind of gelatinous actually, but it's movable. It's mobile. You'll see it move. It's not confined to one area. Unlike cephalohematoma, cephalohematoma is a collection of blood between the surface of the cranial bone and the periosteal membrane that covers that bone. The blood gets caught in that area, and eventually it will reabsorb. But what you would expect to see when it does reabsorb is an increase in bilirubin as those red blood cells begin to break down. Skeletal system. These issues or concerns are normally observed during the assessment of the newborn. The assessment of the newborn is very thorough, and we'll go through that. But one of the things that you're assessing for is congenital hip dislocation. And one of the ways that you observe it is part of the assessment is Orlani's movement. And in Orlani's movement, you will hear a clicking when you maneuver the baby's legs and hips to rotate and see if there are any restrictions or any clicking sounds would be a positive Ortolani's maneuver, and that would be noted. So the neuromuscular assessment, it's almost completely developed system, is almost completely developed at birth. Um, this tool shows a series of assessments that are done to the newborn, taking the newborn through these assessments to determine the development of the neuromuscular system. So the newborns progress through a hierarchy of behavioral developmental challenges, regulating their physiologic or autonomic system, regulating their control or the motor behavior, um, the ability to modulate the state of consciousness, attention, and social interactions. We talked about the sleep-wake states, the 6 states that form um, the the newborn's level from deep sleep to extreme irritability. Um, the ability to make smooth transitions between these states is called state modulation. So some of the behavioral characteristics are broken down here. Some of the factors including behaviors of the newborn, influencing behaviors of the newborn, their gestational age, the time in which the test or assessment is done, the stimuli, any medication that mom has taken or baby may have had at this point. Sensory behaviors, you want to check the vision, the hearing. There's usually a routine hearing screening done before the baby is discharged from the hospital. Others are smell, taste, and touch. And then response to environmental stimuli, such as temperature, consolability, irritability, crying. So what you see here are newborn sleep wake states. Letter A is deep sleep. B is light sleep. C is drowsy. D is quiet alert. E is active alert. You see the eyes are open, it's awake, it's looking at everything around it. F, of course, is crying. So the healthy newborn has sensory abilities that indicate a state of readiness for social interactions. And you can tell which of these newborns are ready for social interactions. Sleep-wake states and other factors influences the newborn's behavior. And their behavior can progress from self-regulation of their autonomic processes to full social interaction. And of course, each newborn has a predisposed capacity to handle all of the multitude of stimuli going on around them. So we're at chapter 24 now. We're going to look at nursing care of the newborn and the family. So care management, these are all of the things that the nurse is responsible for during the period of the birth through the first 2 hours after birth. And it begins immediately with an assessment, immediate care after the birth, initial physical assessment, APGAR scoring. And the APGAR score represents assessment of the heart rate, the respiratory rate, the muscle tone, reflex irritability, and generalized skin color. So I mentioned earlier there are tools that are used to facilitate the assessment of the newborn. One of the areas of assessment is gestational age. There are situations when babies are born that look to be full term. They may be an average size baby. However, when you assess them, you may notice that the baby is large for its gestational age, or they may be small for their gestational age, or they may be average for their gestational age. And with each of those categories come different strategies for caring or managing the care of that newborn. So two of the tools that can be used, you'll hear them referred to as Dubowitz or Ballot score. It measures the weeks from conception to birth. It's used to identify high-risk infants. And it looks at neuromuscular characteristics, the posture, whether there's more or less flexion. A square window determines more or less pliability, arm recoil, popliteal angle, scarf sign, and heel to ear. And you're looking for resistance. These characteristics are indicators of neuromuscular status of the newborn. Of course, in the general assessment, the physical assessment, you want to look at the general appearance of the newborn, the vital signs, the baseline measurements of the physical growth, the weight, the head circumference, the body length. Neurologic assessment, those are assessed through the newborn's reflexes, the gestational age assessment, as I just mentioned with the Ballard score or Dubowitz, and classification of the newborns by gestational age and weight, or one of these three areas. They can either be appropriate for their gestational age, they can be large for their gestational age, or small for gestational age. And this is the tool that I mentioned earlier. You should have a copy of it in your textbook that shows how that assessment is arrived. You'll see that each of these categories, these are the categories, and these are the assessment findings. There are scores that the baby receives for all of these areas of assessment, and then for the characteristics of neuromuscular maturity. And then there are categories and scoring for physical maturity. And then a final score is derived. Physical characteristics, you're looking for things like the skin. Is there any deep cracking, any vessels seen? If you see deep cracking, baby may be an older infant that's more mature. It may be a 41-week gestation versus a 40-week gestation. Post-leathery skin is another finding. Lanugo, there should be less lanugo present as the baby ages. The planar creases, there should be more with age. So a preterm baby will have a very smooth skin on the bottom of the feet. Or with a baby who is more advanced age, you'll see more creases on the foot. The breasts, we want to look at the areola. The size may be larger or smaller. Eyes and ears, they may be stiff. You know, you bend the ear down, it may pop right back up, or you bend it down and it may slowly recoil. Genitalia, with the males, there may be deep rugae on the testicles. They may be pendulous. For the female, is the minora covered or not? And then gestational age and size may not correspond. So small infants are small for gestational age, are less than 10% for weight in their assessment. The large gestational age, greater than 90% for their weight. And appropriate gestational age is between 10 and 90% for their weight. So you look at those physical characteristics based on the baby's weight, and a gestational assessment is score is derived. And here is the tool by which that's done, a part of the tool. So you're graphing the gestational age of the baby with the weight of the baby, birth weight of the baby, to determine if they fall in the 90th, the 50th, or the 10th percentile. And then if they are large for gestational age, appropriate, or small for gestational age. Immediate interventions for the newborn, of course, always airway maintenance, maintaining an adequate oxygen supply, maintaining body temperature, eye prophylaxis to prevent ophthalmia neonatorium or neonatal conjunctivitis. Vitamin K prophylaxis, we mentioned that the baby receives a vitamin K injection. And of course, promoting parent-infant interactions. From the first 2 hours after birth until discharge, the management focuses on common newborn problems, birth injuries, retinal and conjunctival hemorrhages, soft tissue injuries. There may be some ecchymosis, some tachypnea, trauma secondary to dystocia, or accidental lacerations, which can occur during delivery, maybe spontaneous delivery, but it's more common with a mechanical delivery or mechanical assisted delivery, such as the case with forceps used during delivery. Some additional common newborn problems, physiologic problems, are what we spoke of earlier, hypobilirubinemia, and assessment and screening. Every newborn should be assessed for jaundice at least every 8 to 12 hours. You should check the total serum bilirubin levels, the transcutaneous bilirubin levels, and then make sure that there are adequate feedings in order to prevent hyperbilirubinemia. Remember, the feeding helps to get the bilirubin out of the baby's bloodstream. And of course, there are therapies that can be used. We talked about the phototherapy, but in extreme cases, there may be an exchange transfusion necessary. Common newborn problems, hypoglycemia. This is usually defined as blood glucose levels less than 45 milligrams. Infants at risk for hypoglycemia are preterm or late preterm, SGA, or LGA, low birth weight, infants of mothers with diabetes, and infants who experience perinatal stress, such as asphyxia, cold stress, or respiratory distress. Nurses should observe all newborns for signs of hypoglycemia. Still during that 2 hours after birth until discharge, we're assessing labs, and we're doing diagnostic tests, universal screenings. There are some screenings that are required for all infants. It's mandated by law, and that's to detect early detection of genetic diseases that can result in severe health problems if not treated early. There are also routine hearing screenings done and screening for congenital heart disease. Collection of specimens or blood specimens are usually collected via heel stick. It can be venipuncture. We also collect urine specimens if that's necessary. The nurse is responsible for providing a protective environment Environmental factors. You want to maintain environmental factors that can pose risk or harm to the newborn. You want to maintain infection control, prevent the infant from being abducted. That's all in the safety realm. You'll see that many hospitals have instituted several different layers of safety measures, such as making sure that there are sensors at the door of the area where the babies are kept. There may be scanning devices on the babies. The hospital staff has been alerted to note if any baby in one of the blankets out of the labor and delivery unit or the nursery area is on a baby as they're going through the hospital. That there should be no babies in blankets leaving that area. So that's one of the safety measures. And definitely preventing newborn injury and teaching the family to prevent newborn injury, such as not placing the baby on the bed or in an area where it can fall, not placing the baby in an area where there are lots of covers where their breathing can be obstructed. Therapeutic and surgical procedures, of course, intramuscular injections may be necessary. And of course, the vitamin K is one of those necessary injections. Circumcision, there are policies and recommendations that have to be followed. Parental decision in terms of the circumcision. There are a couple of different types that are listed here, but you can read more about them in your textbook. Yellen, Mogen clamp, or the Plastibell device. And with the Yellen or Gumco and the Mogen clamp, those types of surgical procedures will require just keeping the head of the penis clean, dry as much as possible. The Plastibell is a plastic covering that protects the skin of the penis after the circumcision, and the plastic covering eventually falls off. There is procedural pain management that is used, and it's different at different facilities. But of course, you want to make sure you maintain care of the newly circumcised newborn. This is more information about the pain and how to notice a baby's response to pain in order to respond appropriately as a nurse. The most common sign is crying. You notice when the babies are prepared, they don't like to be strapped down for the circumcision, but when the procedure starts, you will notice a loud cry. They're in pain. Changes in the heart rate, their blood pressure, intracranial pressure, vagal tone, respiratory rate, oxygen saturation. All of those changes occur in response to neonatal pain. These are some of the measures that you can use to assess the pain. You also want to do what you can as a nurse to modify the pain or modify the perception of the pain, because the pain is there, but babies like to be swaddled. So you notice in both of the pictures on this slide, after a procedure such as circumcision or heel stick, you may want to swaddle the baby firmly. They like to suckle, so either put them to the mother's breast, or if they're sucking a pacifier, or some baby really, they are able to self-soothe themselves. And the goal of pain management is to minimize the intensity, maximize the neonate's ability to cope with and recover from the pain. swaddling, non-nutritive sucking, oral glucose. These are non-pharmacologic measures where the nurse may, using a gloved finger, put her finger in glucose water and allow the baby to suck on the finger during the procedure. If you can provide the baby skin-to-skin contact with mom or breastfeeding during the procedure, that can help. But there are pharmacologic management techniques, and those include local or topical anesthesia, which can be used and is used in some cases for procedures. And then based on how much anesthesia the baby needs, then there are other options there, as you can see. Promoting parent-infant interaction, that is one of our primary responsibilities, is to teach the parents, but also to promote bonding. Remember, all parenting does not come naturally for all parents. So it's important that we assess the level of attachment. If the parents or family are seemingly not showing attention to the baby, they're not bonding with the baby, then those are assessment measures. I mean, those assessment that assessment needs to be addressed with the parents, possibly involving others to ensure that before the baby is discharged, that the concern has been addressed. Support and education for the parents, and also cultural considerations. You have to take culture into consideration. And always discharge planning begins early too. So set priorities for teaching. Of course, as a nurse, you follow the parental cues. If there are knowledge deficits or gaps, they should be identified before beginning to teach. So you observe first and you teach next. You definitely want to teach them about temperature, respirations, and how to use a bulb syringe, feeding, what's normal feeding pattern, elimination, what's a normal elimination pattern. We talked about weighing the diapers to see how much the baby has urinated, if there's concern about that. We talked about the different cycles of stool and what the parents should expect with that. Sleeping positions, holding the baby, safe sleeping position, back to sleep. You want to educate them about SIDS and how to prevent or reduce the risk of SIDS. You talk about rashes, diaper rash and other rashes, when to notify the healthcare provider, clothing, car seat safety, pacifiers, bathing, umbilical cord care. The baby will have the umbilical cord clamp removed typically before it's discharged. If the ends are dried enough, then that will come off. And you want to talk to them about care of the umbilical cord area, skin care to minimize the risk of infection. And then follow-up care, when the parents should expect to take the baby in for a follow-up. If there are any reasons they should notify the healthcare provider or contact the healthcare provider before that follow-up appointment. They definitely need to know cardiopulmonary resuscitation, CPR for an infant. And then practical suggestions for the first week home, how to interpret the crying and use of quieting techniques for the newborn, and how to recognize signs of illness. And all of those types of teaching topics are presented to them while they're in the hospital. So whenever you're interacting with the baby, you want to use that as a teaching opportunity for the parents. I hope you have enjoyed. I know it was a lot of information. I know that some of you may not have gathered all that you need, but you definitely need to go back and have a good understanding of this content. It is a lot, But as a nurse caring for a newborn and their family, these are things you absolutely must know. Thank you and have a good rest of the day.